Hello everyone, welcome back. We'll be continuing with our Psychiatry MCQ series. I'm Dr. Swaleha Mujawar, and today we are going to discuss a very interesting topic called as mood disorders. So let's dive in. The topics which we'll be covering is the classification, clinical features, prognosis, etiology, and management. So first, the classification. So, ICD classifies mood disorders into these following. So, as you can see here, this is a normal mood. The yellow line is what we call as a normal mood or a euthymic mood. When you're feeling very high, very happy, so when you're going at this high end of the spectrum, it's called as mania. When you feel very, very low and it's at this opposite end of a mania, it's called as depression. Okay, so what is the classification? One is a manic episode, a depressive episode. Bipolar mood or affective disorder is when you have both these things, mania and depression. Then you can have recurrent depressive disorder, that is, you're having depression uh, recurrently again and again, as it is shown here. Then there is a persistent mood disorder in which there is cyclothymia, that is mania and depression both, and dysthymia is only depression, but for a very long period of time, at least more than 2 years. Then there are other mood disorders like mixed affective episode, in which you have both mania and depressive episode mixed into a single episode. And then there is recurrent brief depressive disorder, in which you have depressive episodes for a very small period of time, but they occur recurrently. That is, they occur more and more times compared to that of a depressive episode. So, we have seen the classifications. There are also subtypes of bipolar disorder. They are bipolar 1 and bipolar 2. In bipolar 1, we have episodes of severe mania and severe depression. In bipolar 2, you have episodes of hypomania. That is, it does not require hospitalization and does not have the full features of a manic episode along with severe depression. Okay, so this is the subtypes. Then let's look at the clinical features. So we have seen two episodes, manic episode and a depressive episode. So first we'll cover the manic episode. A manic episode is typically characterized by the following features, and these features should last for at least 1 week. If the features do not last for a week, we call it as hypomania. Okay, so manic episode is all these things which you can see here lasting for a week. So, how is the mood in a manic episode? It can be elevated, expansive, or sometimes irritable also. So you're very, very happy or sometimes irritable. Psychomotor activity. It is usually goal oriented and based on the external environment. That is, the patient will be doing a lot of work, which is mostly goal oriented. Then speech and thought. Patient is more talkative than usual. Pressure of speech. They'll be talking so much that you won't be even able to ask them a question or put your points forward. This is called as pressure of speech. Flight of ideas means it is like a flight of stairs. There will be interconnected ideas, but the patient will be jumping from one idea to the other. Then delusions can be present, mostly of grandiosity, that the patient feels that they have a lot of money, a lot of power, or something like that. Then other features which can be seen are increased sociability, There can be high risk activities like buying spree, reckless driving, foolish business investments, and giving money or personal articles to unknown persons. So they'll be giving their very expensive watches or mobile phones to just strangers on the street. So this is a very high risk behavior. Then sleep is usually reduced, what we call it as a decreased need for sleep. So they'll be sleeping for only 2 hours or 4 hours, and they'll be very active, very fresh. So if you have less sleep, you're very tired and you have low energy. But patients have a decreased need for sleep and they'll be very, very active with a very small amount of sleep. Appetite may be increased, that is they'll be asking for a lot of food and a very expensive food also sometimes, but later there is decreased food intake because of overactivity. So they'll be doing so much work that they won't have time for eating food. So let's look at a question now. So, a 30-year-old man has decreased sleep, hypersexuality, increased talkativeness, and spent a lot of money in the last 2 weeks. So, the diagnosis is psychosocial development, mania, schizophrenia, or hysteria. So, the answer is, of course, mania, because we have looked at these features before. So, in this lecture, I'll be giving you the explanation or the knowledge first and then asking you the questions. In the previous slides or in the previous lectures, I started with questions first and went to explanation next. So please let me know in the comment section, what would you like? Would you like the explanations first and then the questions, or first the questions and then the explanation? Okay, so let's move on to the next episode, which is the depressive episode. So the typical depressive episode is characterized by the following features, which should last for at least 2 weeks. In manic episode, the features should last for 1 week. Here, these are supposed to last for 2 weeks. So, how is the mood in this episode? Obviously, depressed. But this depressed mood should be pervasive and persistent. That is, they should be continuously having a depressed mood, because sometimes we do feel depressed due to some stressors or something going on in our life, but that does not constitute a depressive episode. The depressive mood should be pervasive, persistent, lasting for 2 weeks for it to be called a depressive episode. Then psychomotor activity is decreased. There is drooping of shoulders. The patient just sits at one place, does not do any work, any household work. So psychomotor activity is decreased. Then there is something which is called as depressive ideation or cognition. These are three in number. They are hopelessness, helplessness, and worthlessness. Hopelessness means there is no hope in the future. Helplessness is that nobody can help them, whatever the situation. And worthlessness means they are worthless. They feel inadequate and inferior. Okay, so the question can be, all are depressive cognitions except. So your options are hopelessness, helplessness, and worthlessness. Answer is D, none of the above. Now, there is something in a depressive episode called as the somatic syndrome. Somatic syndrome is basically characterized by a significant decrease in appetite or weight, then early morning awakening at least 2 hours before the usual time of awakening, then diurnal variations, which means that depression is worse in the morning. Then there is a pervasive loss of interest or loss of reactivity to pleasurable stimuli. This is known as anhedonia. Then there can be psychomotor agitation or retardation. All these 5 things are known as what is called as a somatic syndrome. Okay, so let's go on to the next. Psychotic features. Sometimes in depression, psychotic features can be present. They can be mood congruent. That is, mood congruent means they match the mood. That is, the patient is depressed and the psychotic features also will have a theme of depression. So they can be nihilistic delusions, delusions of guilt, delusions of poverty, stupor, and they are understandable in the light of depressed mood. Mood incongruent, they are not directly related to the depressive episode. So they can be delusions of control or other types of psychotic features which we will expect in a case of schizophrenia, but they can be present here also, and they are called mood incongruent psychotic features. So the question is, common cause of mood congruent delusion is A, schizophrenia, B, paraphrenia, C, paranoia, and D, depression. So answer is depression. So another way in which they can ask you a question is, delusions are found in all of the following disorders except schizophrenia, psychotic depression, mania, and personality disorder. So the answer is personality disorder, because the mood congruent psychotic features or mood incongruent psychotic features, they can be present in depression or mania both. But in personality disorder, no psychotic features are seen. Now, suicide is a very, very important factor, not just in psychiatry, in general. If you have any friends who say they are feeling suicidal, please do not ignore them. Please get them to seek help, because suicide is a very, very important and one of the most common causes for death in psychiatry. So, suicide risk, what are the risk factors for suicide? So, first is marked hopelessness, then males age more than 40, unmarried, divorced, or widowed. Then C, a verbal or a written communication of suicidal intent or plan. Like they are writing a suicide note, they are writing a will. If they are doing something like this, then that means there is a suicide risk. And again, they should seek help with a psychiatrist. Then in early stages of depression, suicide is very common. Then recovering from depression, at the peak of depression, the patient is very depressed or the psychomotor activity is very retarded, so they don't commit suicide. But then, if we give them antidepressants and when they're recovering from depression, they get that energy and there might be a risk for depression. And also, a period of 3 months from recovery is considered a risk factor. So, the first 3 months, the patient should be followed up very closely. So, the question can be, the following are risk factors for suicide except presence of marked hopelessness, B, a married individual, written or verbal communication of suicide intent or plan, and early stages of depression. So, the answer is married. Okay, so all marriage jokes apart, marriage is actually protective in terms of suicide. Now the prognosis. So let's look at some good prognostic factor and some bad prognostic factors for mood disorders. Good prognostic factors are acute or abrupt in onset. Typical clinical features, what we call as a textbook case, then well-adjusted pre-morbid personality and good response to treatment. These are also good prognostic factors in schizophrenia, so they'll be easy for you to remember. Poor prognosis factor, any comorbid medical conditions like diabetes, hypertension, stroke, then personality disorders, alcohol dependence, again, alcohol complicates the things a lot. So all these are poor prognostic factors. Double depression, that is acute depressive episode superimposed on a chronic depression or dysthymia, then obviously if there is a lot of stress going on in the patient's life, like financial problems or family problems, these are again poor prognostic factors. Unfavorable early environment, that is their childhood was very stressful, then marked hypochondriacal features or mood incongruent psychotic features, and poor drug compliance. These are the poor prognostic factors. So the question can be all are bad prognostic factors for depression except A. Comorbid medical disorder, B. Personality disorder, C. Alcohol dependence, and D. Acute or abrupt onset. So the answer is acute or abrupt onset because that is a good prognostic factor. Now let's go to the etiology. So the monoamine hypothesis is seen in which illness? A. Depression, B. Anxiety, C. Schizophrenia, or D. OCD. The answer is depression. So what is the monoamine hypothesis? This hypothesis, it suggests that there is an abnormality in the monoamine neurotransmitters. What are the monoamines? They are catecholamines and serotonin. Catecholamines are two in number, norepinephrine and dopamine. So there are three monoamine neurotransmitters, norepinephrine, dopamine, and serotonin. If these are abnormal in the central nervous system at one or more sites, then a risk for mood disorder is very high. Then some other neurotransmitters like acetylcholine and GABA are also involved. So mood symptoms are prominently present in many endocrine disorders, except your options are hypothyroidism, Cushing's disease, Addison's disease, and none of the above. So the answer is none of the above, because a lot of endocrine disorders can actually lead to depression. So, endocrine function is often disturbed in depression with cortisol hypersecretion, then non suppression of dexamethasone challenge test, which is called as DST, the dexamethasone suppression test. Then there is a blunted TSH response to TRH, that is, your thyroid functions are abnormal. Then there is a blunted growth hormone production during sleep. So all these endocrine disorders or dysfunctions are found in depression. Now let's go on to the management. This is the last part of the lecture, so please be with me. The side effects of tricyclic antidepressants include all except A. Hypertension, B. Dry mouth, C. Diarrhea, and D. Blurred vision. So the answer is C. Diarrhea. So first let's look at what are the antidepressants. Antidepressants can be tricyclic antidepressants like imipramine and amitriptyline. After tricyclic antidepressants, the newer antidepressants are known as selective serotonin reuptake inhibitors, which are fluoxetine, sertraline, citalopram. Other antidepressants are mirtazapine, then SNRIs, serotonin norepinephrine reuptake inhibitors like venlafaxine and duloxetine. So, out of all these antidepressants, tricyclic antidepressants were used very commonly because at one point of time there were no other antidepressants. But these tricyclic antidepressants had side effects which are known as muscarinic side effects. And in these newer antidepressants, these muscarinic side effects are not present. So, what are the side effects? The autonomic or the muscarinic side effects of tricyclic antidepressants include dry mouth, constipation, mydriasis, urinary retention, and sometimes delirium, glaucoma, and hypotension. So, muscarinic side effects means basically all your body secretions dry up. So you have dry mouth, dry eyes, which leads to cyclopegia and mydriasis. Decreased secretions in your GIT leads to constipation, and in your urinary tract, it leads to urinary retention. So these side effects are more with TCAs, but less with the newer antidepressants. Now, another question can be lithium carbonate therapy is useful in the treatment of A, anxiety, B, schizophrenia, C, OCD, and D, mania. So the answer is D, mania. So lithium has traditionally been the drug of choice for the treatment of manic episode, that is the acute phase, and also in the prevention of further episodes of bipolar mood disorder. So it's a very old drug, time tested drug, very useful in mania. It is also used in the treatment of depression, but we don't use it very commonly. We use it only for resistant depression, in which all the other drugs are not working. But yes, it can be used in depression also. Another question can be, a patient is brought to the casualty in a state of altered sensorium. He was on lithium treatment for bipolar affective disorder and has suffered through an attack of epileptic fits. On examination, he has tremors, increased deep tendon reflexes, and urinary incontinence. He has also undergone an episode of severe gastroenteritis 2 days ago. The serum lithium levels were 1.95 millimoles per liter. So, what is the diagnosis, or what is the cause of the condition? A, lithium toxicity because she's on lithium. B, dehydration because she had gastroenteritis. C, manic episode. Or D, depressive stupor. So, the answer is A, lithium toxicity. So, C, lithium has a therapeutic dose range of 900 to 1500 milligrams of lithium per day. Lithium treatment needs to be very closely monitored. Why? Because the difference between the therapeutic index, the therapeutic blood levels, and the lethal blood levels is not very wide. This is known as a narrow therapeutic index. So, because lithium has a narrow therapeutic index, we have to closely monitor the blood levels. As you can see here below, the therapeutic blood levels is zero point 0.8 to 1.2, prophylactic is zero point 0.6 to 1.2, but if it goes more than 2, then toxicity is there present, and if it is more than 2.5 to 3, it can also be lethal. So you have to be very, very careful, because there is a very small difference between the therapeutic levels and the lethal levels or the toxic levels. So the answer is lithium toxicity, and whenever you're prescribing a patient lithium, please monitor the blood levels repeatedly. Okay, so with this, we finish this lecture. Thank you so much for listening. I'll see you again in the other lectures.